We can shift a little bit. Maybe I'll come back to the sentinel lymph node. I mean, we use one example, it's very clear cut. But no, I know there are some controversies at one point. Let's say you find the lymph node to be positive, the procedure is complete lymph node dissection. And I understand this is sort of, we're shifting away from all of that. Maybe you can give us some comment and like what is the complete lymph node dissection and the complication rate and why are we sort of shifting away from that?
Sure, yeah. As we approached this sentinel lymph node biopsy thing, and we realized not everybody was benefiting from the upfront lymph node dissection, particularly the patients with a negative sentinel node, we kind of assumed that if you had a positive node, you should have this big lymph node dissection. Now, lymph node dissections in and of themselves are not terribly difficult or dangerous operations, but they are fraught with short and long-term complications. And particularly in the groin area,
sure.
Wound complication rate can be 10 to 20%, meaning poor healing, wound infection. But probably much more importantly, the lymphedema rate after the swelling in the leg rate after removing the lymph nodes in the groin area, probably everybody gets some lymphedema. It depends on sort of the threshold that you use to define swelling in the leg. But if you ask patients, they will tell you, my leg doesn't feel the same after I had these lymph nodes out. In the arm, it's much less so. In the head and neck area, it's not so much swelling, but it is nerve damage. And so the harder you look or the more you ask patients, you will hear that removal of lymph nodes is not a complication-free endeavor. And kind of similar to why we gave up doing upfront lymph node dissections, because we recognized that so many people had negative nodes and probably weren't deriving any benefit and sustaining all the complications. As we were doing the completion lymph node dissections, we realized that most of the patients who we did a completion lymph node dissection had negative nodes as well. And again, I give Don Morton huge credit for this. He said, well, okay, let's have another prospective randomized clinical trial where people with a positive sentinel node get a lymph node dissection up front, and they sustain all of the complications that we've just talked about. Or let's not do a lymph node dissection and just follow people very, very carefully. And this included lots of physical exams and x-rays, and even ultrasounding the lymph node base to find the earliest trace of recurrent melanoma there. And what he found was that if you followed patients, if you did an upfront lymph node dissection, completion lymph node dissection, or followed patients and only did the operation if you found recurrence in the lymph nodes, the survival was exactly the same. It was completely indistinguishable. And the great thing about that trial was there was another German trial going on at the same time, which found exactly the same thing. And I was involved in the sort of safety review of the Morton trial, and I was asked to review the paper which was published, and then asked by the New England Journal to write a short editorial about it. And this has nothing to do with me, but I wrote that this is these two trials taken together are unequivocal and practice changing. And the New England Journal wrote me back and said, we don't use words like that in the New England Journal. And I kind of arrogantly said, well, if you're not going to use them, you have to find somebody else to write the editorial, because that's what they are. And they blinked and they published that it was practice changing.
Yeah, I remember you mentioned in that I remember when the study was coming out and you were going over this data with us during one of this the melanoma group meeting. So I remember that moment very well. And so is it safe to say at this point, I mean, at least at Sloan Kettering and your colleague and your team is no longer moving towards the complete lymph node dissection at this point, especially given all this immunotherapies and all this the progress with the medical oncologist field, everything.
I want to comment on that because we did not participate in that clinical trial, the MSLT2 trial of completion lymph node dissection versus observation, principally because we pretty much felt that the completion lymph node dissection was a waste of time. Yeah. And so we offered patients a choice of no lymph node dissection, close follow-up, or completion lymph node dissection. And the patients were very clear about voting with their decisions. And we said, we can do whatever you want. We don't know that it's safe, but we know we're going to follow you carefully. And by the time those 2 randomized trials were published, 100% of our patients across all of the disciplines in medicine and surgery had elected no completion lymph node dissection. Yeah. So the patients had kind of figured this out. Now, here's the very interesting thing about prospective randomized trials, which I hope is of interest to your audience. The National Cancer Database, there was a paper written that suggested that when completion lymph node dissection was kind of mandated as the standard of care, up to 50% of patients were already saying, I don't want it.
Yeah.
Okay. And that was, to me, fascinating. And most of these were patients who were not associated with big.
And they didn't want it. Is it because once they heard about the complication and the lymphedema and all that? Because at that point, we weren't really sure about the overall survival, right?
Right. That is 100% correct. That's 100% correct. But again, when we were saying we're not going to do it, we said, well, we're going to follow you as if you were in the trial. So we're going to do ultrasounds. We're going to be all over this. You're going to have to, if you're not going to have this, you got to come back to us for lots and lots of follow-up. And it worked out because we didn't find any difference either. Looking back, not as valid as a prospective trial. The period on this sentence is that they recently looked at the rate of completion lymph node dissection after those trials were published. And still about 35% of patients are being told they need a completion lymph node dissection. So even 2 randomized trials and an abundance of retrospective data were insufficient to change the practice of surgeons who still thought there was value to that operation.
I mean, I think this is why, this Beating Melanoma project and your time and your insight is very valuable, right? Because not everyone will have access to you. So, when people watching this, listening to this, and hopefully they have a better understanding about how to make the decisions.
Yeah, I think they do. I agree with you.